Welcome to the Motivational Midwife. My name's Lynn Jones, and today we're going to look at the first stage of labour. So let's look at labour, and specifically the first stage of labour, and this will be a little bit of a whistle-stop tour of labour, and I would strongly suggest that you go back to your textbooks and also your university resources to look in more depth at what's actually happening. We will touch on some of the physiological things that are happening in the first stage of labour, but this would turn into an extremely long session if we went into everything in minute detail. So we'll just have kind of the edited highlights of what's actually happening. So when we're looking at labour, we need to think about what is labour, and really from a historical perspective, we've divided labour into sections for ease of teaching really what's happening in each of those stages of labour. But labour really isn't nicely marked into different stages. It is a continuum, and we've over the years we've almost come to, we've created another stage of labour in that latent phase, and we've become quite dismissive of that phase, which for many women, that early stage of labour is actually one of the most difficult stages. And really, as a midwife, it's where a lot of your skills can come into play, helping women actually cope with that early stage of labour, which for some women can be extraordinarily draining, particularly if there's a bit of a malposition. But we won't touch too much on those today. We're going to look really at normal physiology of a normal labour. We deem, I like Dennis Walsh's definition here, which is on the screen, but the RCM also do a very good one. But you do need, as I say, to remember that it is a continuum. It is a physiological process, which over the years we have systematically interfered with, and then we wonder why we have problems. There are times when intervention is extremely appropriate, but we've become very fixated on time and time of each stage of labour. And if women don't conform to those time frameworks, we become quite interventionalist, without really looking at the whole picture and the well-being of the mother and the baby. So really, I would say, intervention is appropriate on occasions, but look holistically at the whole picture, and don't just be ruled by the guideline says we have to do A, B, or C at this point. You need to really be thinking outside the box and also advocating for that woman. Still enough of my soapbox. So characteristics of a normal labour is there's uterine contractions. Okay, the uterus contracts, and this in turn will cause effacement and dilatation of the cervix, which in turn will help the descent of the baby through the pelvis until it's born. So, as I've said, stages of labour have been divided quite nicely into three, although we've had this extra fourth stage of labour, the latent phase, which is deemed to be until a woman is regularly contracting and the cervix is 4 centimetres. Now, again, look outside the box. If you have someone coming in who is contracting irregularly, and this does happen, particularly with multips, and you've examined them, but their cervix is 4 centimetres, but they're having irregular contractions, not lasting particularly long. Are you going to say she's in established labour just because her cervix is 4 centimetres? So think carefully about that, because actually I would say, no, she isn't. She's not established yet. And, you know, certainly in my career, I've had women who have been 5 or 6 centimetres and not contracting at all. So be careful about cut-off points and being very rigid in your approach with these things. So for the purpose of these sessions, we're going to look at these definitions. So the first stage is really from the onset of regular uterine contractions, progressive effacement and dilatation until full dilatation of the cervix. And then the second stage would be from that full dilatation until the birth of the baby. And the third stage from that birth until the placenta, cord and membranes are delivered, and also importantly, the bleeding is controlled. So what's actually going on? So let's think about this. So often in late pregnancy, women develop an increase in their Braxton Hicks contractions. So they're what's deemed to be practice contractions. They get these uterine contractions, but they tend to be, for some women, they can be really quite uncomfortable, but generally they are painless contractions. And there is some school of thought that these Braxton Hicks actually, particularly for primates, might aid the effacement process in the last 2 or 3 weeks of pregnancy. And that's the collagen fibres in the cervix actually become more soluble, so they are more susceptible to starting that effacement process. And thinking about the hormones that are involved in all of the labour process, you've got your progesterone, you've got your prostaglandins, you've got relaxin, estrogen and prolactin. They are the key ones that we think about when we think about labour and what's going on with labour. And so when you're looking at hormones, particularly the care that you're giving in labour, think about the things that will encourage some of those hormones and the things that will actually inhibit production of some of those hormones, because those things, those external factors, will have an impact on the labour. As you get progressive effacement. So effacement really is that taking up of the cervix, and I've got a little video afterwards which I'll show you, which I cannot take any credit for. I found it on YouTube some years ago, but it is something I use a lot when I'm teaching, particularly hypnobirthing, to parents, to explain what effacement is, because sometimes it's quite a difficult concept to get your head around what exactly is going on here with effacement. Excuse me. But what's actually happening with effacement is that cervix is being taken up, so it actually becomes one with the lower segment. So the internal os, so your cervix is that tubular structure. You have an os, which is the sort of whole bit at the top and at the bottom, and the internal one, the one that's inside closest to the baby, as it's being taken up, becomes more funnel shaped like this, and then it actually forms part of the lower segment of the uterus. So if we have a look at this little balloon trick here, which, as I say, I can't take any credit for, and if I could remember the lady who I first saw it on, I would give her credit. That there's the cervix, it's long, it's uneffaced. Okay, but with these contractions, can you see that the contraction is pulling up the cervix? So you are getting progressive effacement, or the taking up, so the length is becoming less, and then the contractions will start on the dilation of the cervix. Okay, with primates, these processes tend to happen effacement first, then dilatation, but with multips, both of them often happen simultaneously. So looking at contractions, well, they're involuntary. We can't make us ourselves have a contraction. They tend to be intermittent. You need that gap between contractions to allow the resting tone, which will fill the placenta again with lovely oxygenated blood. So it's important that you do have a resting tone between these contractions. And whilst they start off irregular, a pattern usually forms and they become regular. And often they are, we're looking for sort of 3 to 4 contractions in a 10-minute period. So they're generally lasting somewhere between 50 and 70 seconds, but you need that nice 90-second, 60 to 90-second resting tone to allow the placenta to really refill with oxygenated blood. For most women, they are painful, and there is a school of thought that this might be due to the ischemia that's happening in the muscle fibres, because we'll talk about retraction in a minute. They start at the cornua, so the sort of horny bit of the uterus, and then they come in a wave-like fashion downwards and across. So they're coming inwards and downwards across the uterus, and this is known as fundal dominance. Okay, so they're much stronger at the top, where the muscle fibers are thicker than the bottom. Okay, so the lower segment. Okay, the lower segment there is thinner. There is less myometrial fibers there. It's much thicker in the fundal area, and so you get a stronger contraction at the top of the uterus. The lower segment does this very slightly. So what this causes is that as the muscle fibers contract at the top, the more passive lower segment will respond to that pulling up. And they tend to be quite coordinated, okay? And this is because the myometrial cells, as you get towards the end of pregnancy, between each cell they form something called gap junctions, okay? And gap junctions are like little connections between each cell that will aid that communication between each cell, so that you have a lovely coordinated action of those muscle cells. And remember, your myometrium is your muscle layer of the uterus. And what happens then when you get the muscle contracting is, normally you would have a muscle contract and then relax, and it will go back to its contracted state and length. But uterine muscle, when we're talking about labour, does something called retract. So every time the uterus contracts, the muscle fibre never quite goes back to the length that it was before it contracted. So it becomes a little bit shorter. And as the top muscles become shorter, it will exert a pull on the lower segment. So this is how that cervix starts to be pulled up, and so you get that dilation. And if you think back to the balloon, you can see it being pulled up as every time I squeeze the balloon, so that would be the contraction, and you have that pressure as well, it's being pulled up. Now this is also aided by the baby, because as you get the fundus contracting, this will exert what's called fetal axis pressure. So the baby is usually in a longitudinal lie, and more often than not, it's the bottom that's at the top. So as the uterus contracts, it will press on the baby's bottom, and that will exert a pressure along the long axis of the baby, which will encourage the baby's head to flex, and that will exert pressure on the cervix, which will aid dilatation. But what it also does is it causes a reflex release of oxytocin. We've said oxytocin is one of our lovely hormones that we need for labour, and so that will help with the contractions, and then it's that circular. So you get another contraction, more fetal access pressure, more oxytocin release. So it is a nice circular pattern. So thinking about membranes and fall waters. Now, many women think, because we talk about forewaters and hindwaters, that they've actually got two separate bags of waters. And so it's useful to explain sometimes to women that the forewaters are actually formed as the baby's head comes down and essentially plugs the space, so that a bag of waters actually forms in front of the baby's head. And what that does is equalize the pressure in early labour. So when you've got that fetal access pressure and the baby is pressing down, it equalizes the pressure on the cervix. And we've said already about the descent and the reflex oxytocin release. And you also have, as the cervix starts to dilate, you will get your apiculum, which is your show. Okay, and that's the mucus plug bit separating from the cervix. Okay, so it can be quite blood-stained, because it separates from the sort of chorion and the decidua around the cervix. So as that's separating, all those little blood vessels will often cause a little blood to be in there. And sometimes it can be quite a lot, actually, to be. Some women have quite a heavy bloody show. But most, it's really quite mucousy and quite lightly blood-stained. So let's think about our care in labour then. Okay, most importantly, it needs to be individualised and you need to work in partnership with the woman. It's always useful, and my personal practice is I will always ask women, have they written a birth plan? You know, if they've gone to the trouble of writing a birth plan, the least you could do is read it. And actually it does, if they've written a birth plan and you're reading it, it does cut down on the time that you're actually interfering in their labouring process by asking a lot of questions, because you can see what their wishes are. They've written it down, and then if there's anything that's not clear or you need to clarify with them, you can focus on those points. So always ask women if they've written a birth plan. If they haven't, labour is not the time to really be making informed choices. And I do feel quite strongly about this, and I find it quite frustrating when women do come in labour and I'll say, oh, did your midwife talk to you about third stage, for example, and what your choices and options are? Well, not really. Or vitamin K. No, what's that then? You know, people should have time to actually process the information you're giving them and then make an informed choice, and they can't really do that in labour, in my opinion. So always encourage women to look at what the evidence suggests for all of their potential options before making a decision. So yes, look at their birth plan or discuss what their wishes for labour are. What did they want? What did they not want? Because this will aid you in your individualised care planning for that particular woman. Environment is something I feel very, very strongly about. And if we think back to the physiology of what's going on in labour, and this is why I say to you it's quite important that you understand what's happening within the body physiologically. We know definitively from animal studies and things that actually environment plays a huge part in the progress of labour. And most women come into hospital to have their babies, and most hospitals are very medicalised. They're not set up really for conducive birthing environments. But there is a lot you can do, and there will be another session on birth environment, as it is something I do feel very strongly about, that will focus a lot more on the things that you can do in the birth environment. But consider the environment and the impact it might have on that labour. Very often when women come into hospital, they've been at home, they've been contracting really well, they come into hospital and suddenly everything goes off the boil. And this will be physiologically because they have had a surge in stress hormones. Even if hospital is the place they want to be, it is still an alien environment to them. and they're meeting people they probably haven't met before. All of those things will trigger release of adrenaline and noradrenaline, which serves to dampen down the effects of oxytocin. And then we've got the physical care in labour and psychological care in labour we need to be thinking about as well. So thinking about some of our more physical care and really labour documentation. Partygrams have been used for many, many, many years, and this is really just a pictorial representation of what's going on in labour, and the picture on the screen is of a partygram. And there are many options of this. This particular partygram has at the beginning of it, which you can see, I don't know if I can get my this bit here, it's obviously got quite a long bit for a latent phase, I'm thinking. And then when she becomes what is deemed to be active labour, they have moved it across to the alert line on this one, because this one has an alert and an action line on. They don't always. You can see at the top here we've got the fetal heart rate, and all those observations have been moved across. That's why you've got a gap. You've got your dilatation here and your descent here. You've got contractions here, and we've got maternal observations here as well at the bottom. So think about bladder care as well. Encourage women to empty their bladder sort of 2 to 4 hourly frequently, really, because any amount of urine in that bladder is going to, if you think physiologically where the bladder is, if it's full of urine, it's going to make it much more challenging for that baby's head to come past. Abdominal examination, particularly before vaginal examinations. This will give you, and remember your abdominal examination is inspection, palpation, auscultation and documentation. Okay, it's not just a palpation. It's much more than that. So this will give you an idea of the position of the baby, and that can also aid in some of the things you might suggest to optimize physiology for her. Undertake a set of baseline observations. So a full set of baseline observations, because this gives you a starting point of where she is. Is everything within the normal parameters that you would expect, or is there something that you're concerned about that you might need to investigate more deeply? And then for labour, currently most trusts follow NICE guidance for care in labour. So if the woman is in established labour, we're looking at doing 4 hourly blood pressures and temperatures, unless she's using a pool for analgesia, in which case temperature should be taken hourly along with the pool temperature. Pulse half hourly, and fetal heart rate quarter hourly. And respiration rate, important not to forget to do your respiration rate as well. And I think I said pulse, didn't I? Say it's your temperature, blood pressure, pulse, heart rate, respirate. In some hospitals that also do a baseline saturation, oxygen saturation rate as well. They have the little tiny finger probe that can go on without being attached to monitors of all sorts. Ask her about any vaginal loss she's had. So has she had a show? Keep monitoring the vaginal loss. Have her membranes ruptured? What colour were the membranes? Are they, is it clear? Is it pinky? Is it meconium stained? Once her membranes rupture, is the show, if it's blood stained, is it of an amount that you are confident it is just show, or is it more than that? Do you need to get her reviewed? Look about her mobilizing in the position she is adopting in labour. Partogram we've discussed. Vaginal examinations, and you can see that's really quite way down the list, because, as I say, they are not a definitive, whilst they are useful, they are not a definitive tool to be used. So vaginal examinations, and the key word that NICE use, should be offered every 4 hours. Okay, so not thou shalt do every 4 hours, but thou shalt offer a woman a vaginal examination. And if she chooses to decline, then you respect her decision to decline, but you might want to explore her reasons for that as well. But this may be in her birth plan anyway. And as I say, they are a very subjective assessment, vaginal examination. So whilst they are or can be useful, they need to be in context. And then think about analgesia. Does she want, what sort of options does she want? What options are open to her? Has she had the information of the pros and cons of all the choices that are available to her? And lastly, documentation. My personal practice is that I document every 15 minutes, and I am looking at how is she coping? Are we encouraging fluid and food intake? She needs to be well hydrated and fed if we're going to provide energy for that uterine muscle to actually work efficiently. We've said about a bladder care, so I'm documenting when did she last void, what's the length, strength, and duration of the contractions are, and really that you need to put a hand on the fundus to palpate length and strength. Don't just assume because she's very distressed with them that they must be very strong. They may not be. They may be quite moderate or mild on palpation, and another woman who is really coping very well, and you think, oh, she's not really in labour. She doesn't seem to be in labour. When you actually palpate the contractions, they're strong and they're lasting well. So, you really do need to use the tools of your trade, which is all your senses, so your ears, your eyes, your hands, definitely, to really see what is going on and hone in on how this woman is doing in her labour, and is labour progressing as you would expect it to be. So document how things are going in your contemporaneous notes. Many systems have tick boxy wizards to use that are electronic, but even please do really get into a habit of using your free text to add to the bigger picture of what's going on. A tick box doesn't tell you how she's coping, or often all those other more subtle things. How the partner is, has he been offered any refreshments? Is he supportive, or is he sitting in the corner playing on his phone? There's a lot of extra information you can put into your documentation, but documentation, remember, under your midwife's NMC code, you really do need to be thorough in your documentation. And there you have it, the first stage of labour. I hope you found that useful. If you haven't subscribed to the channel, please do so, and also look for us on Facebook on The Motivational Midwife. I look forward to seeing you next time.